Everyone. Respected Chair, I will be speaking on adherence to anti-glaucoma medication and glaucoma progression. Coming on back to the basics, whenever we see a glaucoma patient, we start on the medical therapy, and checking on any progression, we switch over to the laser or surgical treatment. But most of us miss an important point here, that is checking adherence to the anti-glaucoma therapy. Adherence is the extent to which a patient complies with the physician recommendation. And since glaucoma is an asymptomatic disease over most of the clinical course, so compliance of non-compliance tendency is very much high, and some papers put it as high as 80%. Our study was to check on the adherence to anti-glaucoma and check on the progression in various adherence groups. It was a prospective hospital-based study, and we checked the glaucoma in clinical investigational data at 0 month and 8 month, and checked on the adherence with a 2-scaled questionnaire at the 4th month. 21 eyes were on monotherapy and rest were on the combination therapy. And as per, we used 2 scales. One was visual analog scale and another was Morsky scale. As per visual analog scale, almost 1/4 of the patients were poorly adherent. And as per the Morsky scale, almost 1/3 of the patients were having low to medium adherence. Coming on to the barriers in low adherent patients, we found that cause forgetfulness and side effects were the main reasons for non-adherence, and which we need to tackle in our glaucoma management. Now, relating the adherence with the various personal and demographic details of the patient, we found 2 significant variables. One was the gender and family income. As far gender is concerned, females were having much better adherence as compared to the males, and as the family income grew, so grew the adherence. Coming on to the relation of the adherence with the type of therapy, we found patients on monotherapy were having far better adherence as compared to those on combination therapy. We divided the patients into 3 groups based on the Morsky scale: low, medium, or high adherence group, and checked on the progression in various groups. We checked the best correctal visual acuity progression as regards to ICD-11 classification, and we found 3/4 of the patients in low adherence groups progressed, whereas it was reverse in high adherence group, where only 1/4 of the patients progressed. With regard to the IOP, it was the highest change in IOP was in high adherence group, and it was almost similar in low to medium adherence groups. And coming on to the change in CDR, we found the highest change was in low adherence group. It was almost double that in high adherence group. The highest change was in low adherence group, and it was almost double the high adherence group. And medium adherence group was in between. And coming on to the mean deviation change, it was it followed the same trend as the CDR change. While as RNFL, the RNFL loss in low adherence groups was almost 3 times more than that in the high adherence groups. So in conclusion, we found that non-compliance is a significant limiting factor seen in almost 30% of patients, and cause, side effect, and forgetfulness were the main reasons for poor adherence. And we found 2 variables very positively associated with the glaucoma adherence. One was female gender and monotherapy, and poor adherence leads to a significant worsening of the therapeutic outcome and increase unnecessary surgical interventions. Thank you.
Thank you. Are you a ratified member of the All India?
Yes, ma'am.
What is the membership number?
Sir, it's B22527. B22527. I need to check it. Actually, I'll get it. I think it's.
You can tell us later.
No more question. Preeti.
Based on the patient reporting knowledge.
Yes, ma'am. It was self-reporting. Yes, ma'am.
It was self-reporting.
And
There was no objective way to have it.
ma'am,
Because even on this, patients tend to
bias. Yes, ma'am.
lie.
Yeah, absolutely, ma'am.
So those who have been honest enough to tell you that they've been non-adherent, but even in the those who have said that are adherent, you might have
Ma'am, definitely
objective criteria.
Ma'am, definitely I agree that there is some sort of bias, but objective methods are 2. One is pharmacy based, second is medical, electronic monitoring. But pharmacy based, as you know, here there is no closed pharmacy registration, so that was not possible. And with regard to the electronic, that's not available right now. There is no study in India which has done it, because it's only Alcon funded outside India. So the cost was a big issue. Second is that even if we monitor the patient on electronic, it's not sure that the patient actually put the drop. So they will register. And secondly, there is a Hawthorne effect on even in electronic this screening, electronic monitoring, because patient will tend to increase their adherence because they know that they are under scrutiny on an electronic device.
The idea.
Sir, it was actually different. We used 5 criteria for this. One was vision, and I actually divided differently in all the 5 this parameters. Sir.
Overall incidence of
Progression is, sir, it is almost 3/4 in low adherence and 1/4 in high adherence groups.
Yeah, I think progression, adherence, compliance, all these are all bugbears for our glaucoma management, no doubt about
So
it.
it's a
There's, I
basic-
think, umpteen number of papers, publications, and we are all having this vexing problem of dealing with non-adherence in our own practices. There's so many ways to deal and detect non-adherence and compliance in our practices. I think one way what you have done is, I think definitely we should keep that in mind, that we should make an attempt to pick up a progressing glaucoma patient and see if
Absolutely.
adherence is one of the important causes for the progression, despite everything else you have done. I think you presented well, and thank you. Any
Thanks.
questions from the audience? We just have a couple of minutes to take questions or any discussion points regards to the.
Thank you, everyone.